Hello friends, I welcome you all on this session of Endo Coffee. So before we start, let's grab a cup of coffee. So friends, here we are on today's webinar, that is application of ultrasonics in endodontics. As we all are aware that we are in a phase where this pandemic, that is the coronavirus, has taken all over the world, and we are staying home and maybe utilizing this best of the time in learning, unlearning ourselves, trying out new things, gaining knowledge, etc. So the best way to tackle this situation is staying home and staying safe. So by staying home, we are definitely going to take over this pandemic, and things will go out in a positive way. And tomorrow, when we start our clinic and we join our dental practice, we'll be afresh and we'll be abuzed with a lot of knowledge, and this will eventually help us in some or the other way. So friends, when it comes to retreatment, the image that you see in the front of your screen is the image of our galaxy, that is the Milky Way. And as it is rightly said, the primary endodontic therapy is like the bread and butter of dentistry. But when it comes to retreatment, it is that bread which you don't eat daily. And as you can see, our Milky Way, that is the galaxy, it has billions and trillions of stars. Similar is the case in retreatment. There may be n number of reasons that can actually go wrong, which is related to a case when it fails. Therefore, when it comes to retreatment, there are n number of reasons. Maybe it is the apical third shaping is not done properly, or there is inadequate irrigation, there is a missed canal, and n number of things can go wrong in some or the other way. Eventually, whatever be the reasons, for example, if I'm trying to exclude the reason of a vertical root fracture, then whatever be the reason, my ultimate goal is apical third debridement. Yes, as we all are aware, apical third is one area which shows so much varied anatomy. There are apical deltas, there are lateral canals, it has communication with the surrounding periodontal structures. So the entire bacterial niche is actually accumulated in the apical third. Therefore, to remove this, or maybe to do apical third debridement, our ultimate goal is to do some kind of mechanical instrumentation. Now, whether I have an uninstrumented canal or whether I have an obturated case, in case of a retreatment, the entire goal of my mechanical instrumentation is to create some kind of space in the root canal so that my irrigant reaches the apical third. So the primary goal of any mechanical instrumentation is that the irrigant, my sodium hypochlorite, should reach the apical third. It should, once it reaches the apical third, wherever my files cannot reach, the sodium hypochlorite should be reaching in those areas and cleaning very effectively. Now, suppose I have an obturated case. A common scenario that I have found out among most other dentists is that there is always a race to remove the gada pacha. Everybody is in a hurry to remove gada pacha as soon as possible and to reach the apical third area as quickly as possible. And in doing so, what really goes wrong is maybe a file breaks. And why does this happen? Now, we need to understand that whenever we have a case which is obturated, and if we are using rotary files for gada percha removal, there is a lot of resistance from the gada percha and the hardened sealer, because practically there is no glide path. As we all know that rotary files need some kind of glide path. So in an obturated case, there is no glide path. And on top of that, the rotary file is also cutting some amount of dentine. So the gada percha, the sealer, the dentine, cumulatively they create a stress on the file, and eventually the file breaks. And maybe we might have few other intracanal errors, like maybe there is a ledge, there is transportation, there is strip perforation, etc. Therefore, to overcome this difficulty, most of the dentists, they use some kind of root canal solvents or gadapocha solvents like eucalyptus oil or maybe sandalwood oil or maybe chloroform, halothane, etc. So whatever be the case, one thing that I would like to highlight here, that it has been proven in literature that whenever we are using some kind of root canal solvent, that is always going to interfere with bonding. Now, what kind of bonding am I talking of here? Bonding means basically we are using resin in some or the other form whenever we are doing root canal treatment. So there is resin in our sealer, there is resin in our post-endodontic restoration, there is resin in when we are doing post core. So some or the other form of resin we are utilizing when we are doing a post endodont, whenever we are doing any kind of endodontic treatment. Now this resin should have the ability to bond to the organic part of the dentine. That day I had listened to one of the lectures in national conference by Dr. Prasanna, and he clearly mentioned that the H plus sealer or maybe any kind of resin sealers should have the ability to bond to the organic matrix of our root canal dentine. And if this organic part of the root canal dentine, if it is if it has some kind of oil coating over it, then the bonding is going to get compromised. So my recommendation is to you is that stay away from root canal solvents. Therefore, what is the solution to this problem? I want something that is faster, I want something that is easy, I want something that is reliable, I want something that is safe, I want something that is extended use, and I want something that is economic. So friends, here I would like to present to you these ultrasonic files from Endostar, which are called as endosonic files. And apart from that, the company also has retreatment files, which are called as re-endo files. Therefore, starting with the first primary use of these ultrasonic files is ultrasonic softening of the gadapocha. Now, literature has shown us that that ultrasonics is also one of the method for gadapocha removal. Unfortunately, this part of the area is not much explored by most of the dentists. Therefore, when it comes to gadapocha removal with ultrasonics, as we all are aware that ultrasonic generates heat, and this heat has the ability to soften the hardened gadapocha and the hardened sealers. So as I pass my ultrasonic tip through the gadapocha, it has the ability to remove the gadapocha, or even if it is not practically removing it, it creates some kind of space by which I can use my retreatment endo files and remove the remaining gadapocha from the root canal. This is how it is. Clinically, the endosonic file or the ultrasonic files, they literally glide smoothly through the hardened gadapocha or the sealer. To give it some name, it is almost like I am trying to slice a butter with a hot knife. As smoothly as it goes as smoothly as it can. Yes. Now, once the gadapocha has been removed, and suppose you come across that the gadapocha has not been completely removed, then we go one step ahead and remove the remaining gadapocha with rotary retreatment files. Now, literature has also shown us that whenever we are comparing the efficacy of gadapocha removal with manual files versus rotary files, then definitely rotary files rank far better as compared to your manual files. So gone are the days where I'm using a K file or an H file to remove some kind of gadapocha which is sticking to the walls, etc. Therefore, when it comes to gadapocha removal, if some kind of gadapocha is remaining inside the canal, then I would be using my retreatment files to remove it from the root canal. And the best part about these retreatment files is that they have a fluid design by which whatever gadapocha is there, it comes out of the canal and nothing gets pushed apically. Okay, so here you have seen the main primary application of this ultrasonic files. Apart from that, this this endosonic file is very versatile in nature. We can use these files for MB2 scouting, separated instrument removal, irrigant activation, isthmus cleaning, calcification removal, post removal, and hard to reach area. Let's explore each one of the application. Now MB2. Now friends, I would like to mention here that MB2 is not an extra canal. It is one of the main primary canals when it comes to maxillary molars. Don't believe me? Tomorrow when your clinic opens, go to the dental office, and in case if you have an extracted maxillary molar, have a look at the mesiobuccal root. You will be shocked to see that the mesiobuccal root is thicker buccopalatally as compared to the distobuccal root or the palatal root. So it is thicker buccopalatally because it has to accommodate the second mesiobuccal canal. Now this second mesiobuccal canal is always situated on an imaginary line which joins the MB1 and the palatal canal. Yes, palatal canal. So whenever you have opened the orifice, always look for or always judge the imaginary line that joins the mesiobuccal 1 and the palatal canal. Now, in few cases, there is a possibility that the mesiobuccal 2 canal is slightly situated off-centered towards the mesial aspect, and there is always some kind of lip of dentine that is covering the mesiobuccal 2 orifice. So, in these cases, it is necessary that I trough this or I remove this small lip of dentine so that I can effectively locate the mesiobuccal 2 canal. Once I have located it, I can shape it, I can clean it, and then fill it. So the best method to trough or to remove this lip of dentine which is covering the mesiobuccal 2 canal is ultrasonics. Yes, as you can see in this case, the preoperative X-ray on the left hand side of your screen, this case was reported to us for retreatment, and as you can see on the X-ray, there is a periapical lesion with the mesiobuccal root. The reason for periapical lesion was missed MB2 canal. So with the help of these endosonic tips, the lip that was covering the mesiobuccal 2 canal was removed and we could locate the mesiobuccal 2 canal. This canal was eventually shaped, it was cleaned and obturated. And as you can see the post-operative X-ray on the right hand side of your screen, you can clearly appreciate the resolving of the lesion. Therefore, when it comes to MB2 canal, use the ultrasonic tip for scouting or maybe locating its orifice. Now, moving on to separated instrument removal. Now, whenever a case is referred to me for removal of separated instrument, ultrasonics is always an integral part of my procedure. Yes, practically I would be using ultrasonics almost 99% of the time. So when it comes to separated instrument removal, as an excellent procedure for removal of separated instrument removal is shown to us by Cliff Ruddle, where he mentions to us that we need to always create a staging platform with piezo 2 or 3, and once I have created a staging platform, I use some kind of ultrasonics, the conventional ultrasonic tips like maybe ET25 or maybe some other, and I trough around the broken instrument and eventually the instrument pops out. Unfortunately, in case I have a thin instrument, maybe it is a 10 number or a 15 number K file which are thinner in diameter, then in those cases also I still have to enlarge and create a staging platform with piezo 2 or 3 and eventually use ultrasonics to remove that broken instrument. Because I don't have much of visibility in case if I'm not enlarging till piezo 2 or 3. And in this kind of situation, I am sacrificing a lot of dentine. So with these help of endosonic tips, first and foremost, I do not need much of enlargement like piezo. In most of the cases, I do enlargement only till piezo 1. And suppose even after making enlargement with piezo 1, I have less of visibility. I can thin down the ultrasonic tip and I can effectively remove it from the root canal. Take a look at this case. So this case was referred for broken instrument removal, and as you can see, there are 3 separated instruments in this case. So one is in the coronal third, second is in the apical third, while the third instrument is beyond apex. So the instrument that is beyond apex, we won't be touching that instrument and we'll be keeping that instrument as it is. In case if further needed, we would remove that surgically at a later date. So to remove this broken instrument, we thin down the ultrasonic tips with a burr so that I am reducing the diameter of the ultrasonic file so that I have more amount of visibility, and by thinning down the ultrasonic tip, there is practically no loss of efficiency. So as you can see here, the staging platform has been created with piezo 1 only. So with the help of ultrasonics, I am troughing around the broken instrument, and maybe after few strokes, the instrument now pops out of the canal. There you go. That's the broken instrument, and the second instrument was also removed in a similar way. And if you are comparing the post-operative X-ray to the pre-operative X-ray, you can see not much of dentine has been sacrificed. After the broken instrument removal, the case was referred back to the referring dentist. Coming to activated irrigation, now literature has shown us that whenever we need to remove or whenever we need to clean the intricacies that are there in the apical third, that is the apical deltas, lateral canals, apical fins, etc., irrigation is the only answer to it. And when it comes to irrigation, activation of that irrigant is a primary requisite. Now literature has shown us that whenever we need to rank the different activation methods, passive ultrasonic irrigation is the best method of irrigation or activation of that irrigant. Second to be ranked is manual dynamic activation, and third is the sonic irrigation. Therefore, by activating a particular irrigant, we are removing the air lock or the vapor lock that is present in the apical third of the canal. Yes, so that the irrigant travels now to the apical third, and once it travels in the apical third, it has the ability to enter the lateral canals, the apical deltas, all the internal anatomy, and clean those areas well. Therefore, as you can see with the ultrasonic tip, the transparent sodium hypochlorite that was there has now turned turbid. So imagine the amount of smear layer, the bacterial byproducts, etc., that are being removed by activation of this irrigant. And eventually all of this that has been liberated out of the canal will eventually get flushed out. There you go. Coming to isthmus cleaning. Now isthmus is one area, or it is a narrow lip of dentine that practically joins two or more more canals, and this area has infected or necrotic pulp, or maybe it can have vital pulp also. Now in case if I have a case of which has necrotic pulp, then if I am not cleaning this isthmus, there is a chance that my case might fail over a later period of time. Now this area is not to be shaped with any rotary file, but it has to be cleaned with actively with ultrasonics and sodium hypochlorite. Therefore, as you can see the pre-operative image on the left hand side of your screen, this was a case of retreatment, and as you can see the hardened gutta percha and the sealer that is present at the orifice of the isthmus. So this isthmus was cleaned with these endosonic files, and as you can see on the right hand side of your screen, the cleaned isthmus afterwards. So with the help of ultrasonic files, you can practically and very effectively clean this area. Coming to calcification removal. Now, when it comes to calcification removal, literature has shown us that calcification always proceeds from orifice or from the coronal third of the canal to the apical third of the canal. Yes. Therefore, I can't practically take some kind of diamond burr and my high speed turbine and go through the calcification and locate the canal. So ultrasonics is the only answer to removal of this calcification. So as you can see in this case, the preoperative image on the left hand side of your screen, the entire mesial canal is calcified right from the orifice till the periapical or the apical foramen. So the entire canal was negotiated with the help of ultrasonic files right from the orifice to the apical third. And as you can see the post-operative image on the right hand side of your screen, the obturation and the post-endodontic restoration. Coming to post-removal. Now, whenever we have some kind of passive metal post inside the canal, we can use our regular ultrasonic tip that we use for our oral prophylaxis, and we can remove the metal post from the canal. Or in case if the post is jutting out of the canal, and if I have some space to grasp the post, then I can effectively remove the post with the help of my forceps. However, the same cannot be done with a fiber post, because if I'm grabbing the fiber post with an artery forceps or some kind of forceps, the fiber post breaks. The glass fiber breaks and eventually some part of it is left inside the canal. Therefore, when it comes to fiber post removal, ultrasonics is the only answer. Now, when it comes to fiber post removal, there are effectively two methods. In the first method, I am troughing around the fiber post and loosen it from the canal, and now it pops out, as you can see in this case. But in few cases, if troughing around the fiber post is not possible, then I can go through the fiber post, I can break those glass fibers and effectively remove the post out from the canal. As you can see in this case, this was a case of strip perforation, and in case if I was trying to trough around the fiber post, I would have caused more damage to this case. So we went through the fiber post and the entire post was removed from the canal. Coming to the last section of our webinar, that is treating inaccessible areas. Now, we come across few situations in retreatment that the coronal third and the middle third gadapacha came out in maybe as easy as it could. However, when I'm trying to negotiate the apical third of the canal, which still has hardened gadapacha and sealer, there is some kind of ledge formation or there is some kind of hard stop. And no matter how much amount of filing or K file or H file I'm trying to insert, it is always hitting a hard spot. Even if I am trying to pre-curve the file because the gadapacha and the sealer is hardened, the file does not advance more further. Also, use of gadapacha solvent is not indicated in such cases because, as we have seen in the earlier slides, that that solvents have the ability to interfere with bonding. Yes, therefore ultrasonics is the only answer to treat these inaccessible areas and remove all the gadapacha out and eventually negotiate the areas. Take a look at these two cases. So on the preoperative X-ray that you see on the left hand side of your screen, this case was referred to me for completion of retreatment. And as you can see, the mesial canal is strip perforated and the apical third of the canal could not be negotiated. So the referring dentist used root canal solvents, they used gates, piezos to remove the gadapacha and eventually they strip perforated. Therefore, with the help of these endosonic files, I could pre-curve only the apical third of the endosonic file and glide it very easily in the inaccessible areas. And as I mentioned earlier, that the ultrasonic file has the ability to generate heat, which effectively pierces or penetrates this hardened gadapocha, and eventually the entire canal gets negotiated. And you can clearly appreciate the post-operative X-ray on the right hand side of your screen, which has been obturated with gadapocha, and the perforation has been obturated with MTA. Coming to this second case. Now, whenever we have two canals with a distal root in a mandibular molar, those canals are very commonly situated in the buccal and the lingual direction. But this case was unique because there was a split in a mesial and distal direction. Yes, therefore, the straight part of the canal, that is the distal gadapocha, came out very easily as it can, but the mesial split was very hard to negotiate. Yes, no matter how much I tried to pre-curve my K file, my H file, but the gadapocha was just not budging. Eventually, with the help of ultrasonic tip, as you can see, I have pre-curved the ultrasonic tip, and I have tried to negotiate the mesial split. So, and as you can appreciate the X-ray on the right hand side of your screen, the entire gadapocha is out now. Therefore, in the end, I would like to conclude that this is one device with many applications. Yes, as we all know that our mobile phone, we can use it for n number of purposes. I can use it for my talking. Maybe you're seeing the webinar right now on your mobile phone. I can use it as a calculator. So n number of reasons, n number of areas, or I can use my mobile phone for n number of reasons. So similar is the case with my ultrasonic file or the endosonic files. It is very versatile in nature, and you can use it wherever you get stuck or hard to reach areas. So friends, today I would also like to make another announcement that the next session with Endo Coffee is with Dr. Ayub, which is on Wednesday, who is an excellent speaker from Algeria. These are my credentials, and in the end, I would like to mention here that please stay home and please stay safe. And now we are open to questions. Okay, so we have one question here by Dr. Mansi, and she is asking that what are the settings and the speed for ultrasonic machine to use these files. Now, one thing that I would like to highlight here, that these now there are two kinds of ultrasonic files. One is an ultrasonic file which is a single piece, like from the ultrasonic handpiece to the tip of that ultrasonic, it is one single piece. And there are second type of ultrasonic files where there is a special chuck which gets attached to the ultrasonic handpiece, and eventually these files which are available in loose, I can attach them to the chuck. Now, whenever I am using these kind of chuck files, it is always mandatory that I go one or two settings higher than my single piece ultrasonic file. So, for example, if I'm using the single piece ultrasonic files at a setting of 5, then I would use these ultrasonic the endosonic files at a setting of 7. Okay, coming to the second question, can subgingival ultrasonic scaler be used for irrigant activation? No, it can't be used because when it comes to in case you are using the ultrasonic tip that is used for oral prophylaxis, it cannot enter the orifice because any activation device has to go at least 2 millimeters short of your working length. And as we know that the ultrasonic tips that I'm using for my oral prophylaxis, they are very thick in nature. Maximum they can go only till the pulp chamber. They won't go effectively till the 2 millimeters short of the working length. Okay. We move on to the next question. Okay, so can the ultrasonic files be used in curved canals? Now, as we have seen that these ultrasonic files or any ultrasonic files which are metallic in nature, they are thick and they can be bent to some extent. But still, when it comes to curved canal, whenever I have a case of curved canals, it is always a combination of ultrasonic and manual dynamic activation. So the coronal third and the middle third, where my canal is not curved, I am using ultrasonics, and the area, the apical third, whenever it is curved, I am manually activating it with my Gadapocha. Okay, so the settings that need to be used for removal of ultrasonic, the settings or the power at which I should be using the ultrasonic tips for separated instrument removal. Now I have a satellite P5 booster, and normally I keep it at a setting of 7 to 8, but I would suggest that you do some kind of experiment with your scaler and check out that at what particular settings does it work, because there are different brands of scalers and there might be some kind of variation between different brands. So in case if you're using satellite P5 booster, then 7 to 8 is the setting that I use for removal of separated instruments. Okay, coming to next question. Okay, now there's an excellent question by Dr. Akash that are there any chances of perforation of the canals with the ultrasonic tips? Now there are few ultrasonic tips which are diamond coated. They have some kind of diamond coating on their apical third. So suppose if I'm using these kind of tips inside my root canal, there is those tips are very much aggressive in nature, and in case if I am trying to remove some kind of maybe a separated instrument or maybe for my irrigant activation, then there is a chance that there might be perforation with these cases. Now these endosonic tips, they don't have any kind of coating over it, so they are very much safe inside the canal. Okay, so please use ultrasonic tips which don't have any kind of coating. Okay. There is one question by Dr. Tamer who asked that what are the precautions to avoid post-operative periodontitis? Okay, that is not a scope of today's lecture, so maybe Dr. Tamer can contact me personally and I'll be more than happy to guide him. Okay, we are getting few more questions. Let me check. Okay, so we have one question by Dr. Komal. How to decide to change the tip for separated instrument removal? Now, whenever I have a case of separated instrument removal, I always use a new tip. Yeah. So it is always necessary that you use a brand new tip, because you will have more. The tip will be more efficient and the same work will be done in less amount of time. So use a new tip in case if you have a case of separated instrument removal, or else if you have some other case, please use the autoclave ultrasonic tip. Okay. Question. Dr. Devakant, he has a question. Specification in the last case, specifications must have ultrasonic tips for beginners initially. Okay. So regarding the specification of ultrasonic tips in your last case, Now the last case which we have seen was a case of a mesial split. Okay, so I would like to again explain you the case. Now whenever we have a case where there are two canals in a distal root of a mandibular molar, those canals are always situated in the buccal and the lingual direction. The split is always in the buccal and the lingual direction. However, this case was unique because it had a split in the mesial and distal direction. Now, in such cases, it is we always see that the straight part of the canal, it might be the distal, sometimes it might be the mesial. The straight part of the canal, the gadapocha comes out in very easy manner. But the challenging part here is to remove the gadapocha from the second split. So in these cases, it is necessary that we always pre-curve this ultrasonic file in the apical third only. Keep the rest of the file straight. Yes, and once you have some kind of catch through the gadapocha, you will always feel it with your tactile sensation, some kind of soft spot. So once I feel this soft spot, then I activate my ultrasonic and eventually it penetrates this gadapocha and the canal is negotiated. Okay, so we are done with the question and answers. In case if you have more questions with me, you feel free to contact me personally. I'll be available through on Facebook Messenger or maybe Instagram or maybe YouTube. You can find me anywhere. Thank you, Endostar. Thank you everyone for a patient listening. See you again.